Hello everyone. Welcome to the Osteoarthritis Action Alliance Lunch and Learn webinar for November 15th, 2017. Thank you for joining our presentation this month. Our presenter today is Rebecca Hasson. Dr. Hasson is an assistant professor in the schools of Kinesiology and Public Health and the director of the Childhood Disparities Research Laboratory at the University of Michigan. Her research broadly focuses on the complex causes and consequences of racial and ethnic disparities in obesity and obesity-related metabolic complications among children and adolescents. She'll be presenting today on exercise interventions that work, a recent history of effective exercise prescription. Welcome, Dr. Hasson.
Thank you for having me, and thank you to the Alliance for inviting me to speak on such an important topic. Today, we're going to go over some, as most of you know, the complications of childhood obesity that really are whole body. There's quite a bit of things that happen when a child is carrying excess weight. And we have focused, a lot of research is focused on psychosocial outcomes, so having poor self-esteem, pulmonary issues, particularly asthma or exercise intolerance, gastrointestinal issues, renal, musculoskeletal issues, endocrine and cardiovascular, as well as neurological problems. And this is a publication from Lancet a few years ago, so some of you may have seen this diagram before. But we know that there are a lot of things that are occurring aside from just children carrying excess weight. As an exercise physiologist, my training has primarily focused on how does that excess weight lead to endocrine problems, particularly type 2 diabetes and long-term cardiovascular risk. So looking at things like dyslipidemia, hypertension, and how can we use exercise or prescribed movement or activity to help reduce these complications in children that are carrying excess weight. So for this talk, I want to review a few exercise interventions that have shown significant improvements in cardiometabolic risk factors in children with obesity. So this is pretty much a good news talk. We hear a lot about the bad news, but this talk is really designed to show you different ways in which we can infuse physical activity into children's lives through a variety of different methods. So there's been quite a bit of work on strength training, aerobic exercise training, intermittent physical activity, something that our lab is very interested in, and technology-based intervention. So I'll give you an example from each one of these types of activity interventions, and then we can engage in a nice discussion on which one do you think will work better for the populations that you're working in. So quite a bit of work has been done regarding strength training. What you're looking at now is a systematic review from Natasha Schranz, who recently just reviewed a lot of the literature focusing on the effect of resistance training, not only just on strength and body composition, but also on psychosocial outcomes too. Things like outcome expectations, self-efficacy, or an individual's confidence in their ability to increase their physical activity over a longer period of time. And a lot of researchers have turned to using strength training or resistance training in overweight, obese children and adolescents because they could tend to be more successful in this type of activity because of their excess weight. So because you have a larger mass, you can produce a greater force, and you can see quite a substantial amount of improvements in strength as a function of strength training, even more so than we see in our healthy weight children. So what does the data suggest? So here you can see on the left-hand side is the intervention is not favored, meaning that we don't see improvements in this outcome, versus interventions where we do see a favorable improvement in the study outcome. And if we look up at outcome expectations or expectancy, self-efficacy, self-esteem, we see a nice improvement as a function of strength training. We also see improvements in body composition, whether it's BMI, waist girth, body fat percentage. And then we also see improvements in strength. So probably the largest improvements that we do see with this type of activity is strength training. So these are, in general, most of the outcomes for strength training have focused on psychosocial and body composition changes as well as strength. But one of the things that, as I was a postdoc at the University of Southern California Childhood Obesity Research Center, we were very interested in, again, addressing some of the metabolic outcomes or metabolic risk factors that we see in children with obesity. So we know that children with obesity not only have lower levels of strength, but they also have metabolic abnormalities such as insulin resistance. And they also consume quite a bit of sugar intake. So can we develop a combination intervention that addresses all of these different risk factors for cardiometabolic diseases: insulin resistance, sugar intake, and decreased physical activity participation? So we enrolled 100 obese African American and Latino adolescents aged 13 to 17 years. They were enrolled in a 16-week randomized trial, and the 3 different intervention arms were the control, nutrition education, where the focus was reducing added sugar intake and improving or increasing fiber intake. And then the third intervention group was the nutrition education plus strength training 2 times a week, both upper body and lower body improvements, strength training. So what did we find for the strength and nutrition results? Well, in the combination group, we saw, again, improvements just like everyone else, improvements in upper body strength, improvements in lower body strength, and we saw a decrease in carbohydrate intake. For the nutrition only and the combination group, we saw decreases in total energy intake, decreases in added sugar intake, and decreases in total sugar intake. So the intervention was effective in, again, both improving body strength as well as improving dietary outcomes that are related to type 2 diabetes risk. Well, let's look at type 2 diabetes risk. In this, because this was more of a clinic hospital-based study, we actually assessed insulin sensitivity and beta cell function in all 100 kids, and we used a frequently sampled intravenous glucose tolerance test, and this is where you actually infuse a bolus of insulin and a bolus of glucose into a patient and see how does their glucose and insulin respond. And from that measure, we can get an assessment of their insulin sensitivity and beta cell function, or we call it disposition index. So if we look at the top graph, we can see the white bar is the control group, the shaded bar is the nutrition group, the black bar is the nutrition plus strength training group. And in both African American and Latino individuals, we saw significant improvement in insulin sensitivity with the nutrition group and no change with the combination group or the control group, or actually a decrease in the control group. If we look at beta cell function, we see a really large or a nice significant improvement in the nutrition group again. Again, this is probably driven by the increase in fiber intake, increase in sugar intake that we saw in this group that led to improvements in beta cell function. No change or a decrease in the control and the combination group. But if we look at what happened in the combination group, nutrition plus strength training group, we saw significant changes or reductions in liver fat, and here we were measuring liver or hepatic fat fraction using MRI scans. And we also saw reductions in inflammatory markers. So inflammatory markers related to increased obesity, both amount of fat and inflammation related to that fat mass was decreased in the strength training and nutrition groups combined. So we had different outcomes for the different interventions, but we do see that with strength training, in addition to what other individuals have seen in terms of improving strength, improving body composition, if we combine this with nutrition education, we can also see reductions in inflammation and localized body fat, particularly in the liver. And this is particularly important, particularly in adolescent individuals who are of Latino descent, as they typically gain a lot of fat in that region that leads to increased risk for fatty liver disease and other diseases related to the liver. If we turn to aerobic exercise, this was a study that was published in JAMA back in 2012. And this is another study, again, even though we tend to stay away from aerobic exercise, the literature does, because we know that if kids are not successful in longer continuous bouts of activity, it may actually decrease their self-efficacy for exercise or decrease psychosocial outcomes related to exercise. So we typically try to find innovative ways to infuse physical activity. But this is an important study because the main point was to look at the exercise dose. So again, focusing on type 2 diabetes risk in overweight and obese children, is there a dose-response relationship if we look at aerobic training on insulin resistance, fatness, visceral fat, and fitness in these children carrying excess weight? And do we see any differences by gender or by race? And the spoiler alert is that yes, we do see a nice dose response, that if the kids are doing more activity at a greater intensity, we can see greater improvements in type 2 diabetes risk. So let's take a look and see exactly what they tested. So the objective of this study was to test the dose-response effect of an aerobic training on insulin resistance, overall and visceral adiposity, as well as aerobic fitness. And this group enrolled over 200 overweight or obese sedentary children. These children were a bit younger than what I presented in the previous study. These were on average 9 years old, and about half of them were female, a little over half were female, and the majority of them were Black or African American. This intervention was 10 to 15 weeks long. Again, it was aerobic exercise training that was offered every day after school, so kids were bused from their school to a gym located on a college campus. More of a lab-based study, but it was located more so in a gym. And they also had 3 intervention groups: a control condition, so just usual activity, low dose, 20 minutes of activity, and a high dose, 40 minutes of activity. So all of the kids came in, and every single day they either did 20 minutes or 40 minutes of activity. I'm going to show you a series of graphs, so let me orient you to this first graph because all of the graphs will look very similar to this. You see that there's the baseline condition, and then you have the post-test. So they had measurements at baseline, measurements at post-test, and this is looking at fitness level. And you can see the circles, the black circles is the low dose, the high dose is the black squares, and the open triangles are the control group. You can see a nice increase irrespective of in the amount of activity. We see nice increases in fitness. You do see a slight dose response here. And if we look at insulin area under the curve, so improvements in insulin as a function of this intervention, we see nice decreases, significant declines in both the low dose and the high dose group for the exercise intervention compared to the control. Not necessarily a dose response here, but a nice decrease, just moving, more movement, reduced insulin area under the curve in both groups. Here, though, you do see when you're looking at visceral fat or body fat, you do percent body fat, you do see a nice decrease, dose response decrease. The more exercise you engage in, the larger the decrease in visceral fat and percent body fat. And if we look at the secondary outcomes for this research, we see again trends for significant dose response relationships in the exercise group for fasting glucose. Similarities for fasting insulin, so not really a dose response here, but we do see a dose response in terms of insulin sensitivity measured by the Matsuda index. If we're looking at beta cell function, again, we see it tends to be a dose response, particularly post-test in both of the groups, so a nice increase, a larger increase in beta cell function as a function of doing high dose or 40 minutes of activity. And if we look at subcutaneous fat or BMI Z-scores, again, you see the same trend that there's a dose response. The more exercise you do, the more likely you are to see improvements in some of these metabolic outcomes. So the take-home from this intervention is that 20 and 40 minutes of daily aerobic activity produce significant cardiometabolic benefits in overweight and obese children, but more is better. We do see if we can get children to do 40 minutes every single day, so getting about 2/3 of the recommended dose at a moderate to vigorous intensity, this will enable us to see significant improvements in cardiometabolic outcomes and reductions in obesity-related complications. Well, many of you are probably saying right now, well, how can we actually get overweight, obese children in the real-world settings to do 40 minutes of continuous daily aerobic activity? Can we break up this dose, and can we give this dose of activity into small bursts so that the kids can accumulate this amount of activity rather than doing it all at one time? Because again, based on many of our children with higher weight status tend to have lower levels of fitness, tend to not be regularly active. So how can we accomplish this goal without inducing injury or over fatigue in this group of individuals? So our laboratory was interested in answering that question, particularly as we do a lot of our research in schools, and we wanted to understand how can we induce or implement increased physical activity in schools when we know that we won't have a 40-minute time period to do continuous exercise. Can we actually see if there are any benefits from doing small bursts of activity, 2-minute bouts, and accumulating that over a longer period of time or over an 8-hour day? So our first study that we did was called Active Class-Based, which was laboratory-based, where children came into the laboratory and they did a series of 2-minute activity breaks at a variety of intensities, and we were looking at a range of different outcomes, so metabolic, behavioral, psychological, cognitive, all in pre-adolescent children, ages 7 to 11. Here is the daily protocol. So in order to understand some of the behavioral differences, we wanted to see if we induce or increase physical activity in the laboratory, will the children go home and become couch potatoes? Will we wear them out in the lab? And that's what we don't want to do. We do know that in adults we see a lot of physical activity compensation, to where you might go to the gym, but then the rest of the evening you are watching a lot of TV and not being very active. We also wanted to see if the kids will eat back the calories that they burned in the laboratory, as a lot of adults do that same thing. You go to the gym and then you reward yourself with some sort of candy or treat. So what we did is we had the children consume a standardized dinner before they came to the lab. They ate a standardized breakfast, standardized lunch, and then they were given a large dinner, so it was approximately 70% of the calories that they should be eating, to eat home, to see if they would overeat when they went home as a function of all the activity they did throughout the day. Then we measured their food intake and physical activity at home and 3 days post. So these are the results from the physical activity data. So again, we were interested in understanding when we infuse physical activity, these small bursts, so 40 minutes total, but it was 22-minute activity breaks throughout an 8-hour day. We had a sitting condition where they did no activity, a low-intensity condition where they did low-intensity activities such as stretching, doing different yoga poses for 2 minutes, did a moderate intensity condition where they were just marching in place, getting their heart rates up to about 150, and then a high-intensity condition. Again, 2-minute bouts, and this consisted of doing jumping jacks or doing little obstacle courses, something to get their heart rates up to about 170 beats per minute. What you see here are the number of calories. The white box represents how many calories they burned in the lab, as we had accelerometers on the kids. And then how many calories did they burn when they went home? That is the gray bars. So out of the lab for the rest of the day, for the next 24 hours, how many calories did they burn? And if they were compensating, then we would expect the red bar demonstrates how many calories they were normally burning. So we did have a measure of habitual physical activity. So how much physical activity were these kids doing when they weren't in the intervention or in the study, before they even came? For 7 days, on average, these kids were burning about 270 calories in regular physical activity, so they were pretty active. But you can see here, if they were compensating, then these total physical activity, total energy expenditure from physical activity should be the same across all conditions. But as you can see with the data, that is not true, that in the high intensity condition where they accumulated 40 minutes of high intensity activity, they did not go home and become couch potatoes. They actually burned an additional 150 calories on that day. Now, this is a single day in the laboratory, and so it's important to understand, will they maintain this increased physical activity over a longer period of time? So what do long-term studies look like, where we are constantly infusing small bursts of high-intensity activity into children's lives? Again, will this increase total daily physical activity or total daily energy expenditure? Another question we were interested in asking, again, is will it change their food intake? So they burned an additional 150 calories, particularly on that high-intensity day. Did they feel hungrier on that day, or did they consume more food, either in the laboratory or away from home? Now, in the laboratory, they were given standardized meals, but if the children decided they were full or didn't want to eat, they were not asked to force feed them. They didn't have to force feed or eat the food. They were able to stop if they wanted to, if they felt full during that condition day. So on this left column, we can see hunger sensations. So what we did is 5 times throughout each condition day, right before breakfast, right after breakfast, right before lunch, right after lunch, and right before they went home for the day, they were asked, how hungry do you feel? And you can see across time, yes, that they definitely, after they ate breakfast, they felt less hungry. After they ate lunch, they felt less hungry. So that's what the significant differences that we see are a function of time. If we look at the condition effects, though, we do not see any differences by condition, that across all 4 conditions, the children felt similarly hungry. Down below, we see these are the area under the curve for hunger scores, and this is particularly for the obese individuals or the children with obesity. We did see that they were a bit hungrier from breakfast to lunch on the moderate intensity condition, but total area under the curve for hunger did not change, and lunch to dinner area under the curve for hunger did not change. So we see slight modifications in hunger throughout the day, but when you look at it throughout the entire day, there really wasn't any change in hunger. Well, what about energy balance? So again, did they change their food intake? No. And if we looked at how many calories they consumed versus how many calories they burned, we actually saw a significant decrease in calories consumed, with the amount of calories that they burned versus the amount of calories they consumed. We saw a nice energy deficit during the moderate and particularly during the high intensity condition, where the kids were in an energy deficit of about 300 calories. And this is quite substantial for our children with overweight and obesity, mainly as a function of, we know that we typically, as Americans, overeat or under-exercise by about 100 calories a day. So although this is pretty large, even if the kids were just in an energy deficit of about 100 calories today, over time, if they continue on that trajectory, this may help with weight outcomes over the long term. Again, this is only 1 day in the laboratory, so additional studies need to be done to look at the long-term effects of infusing physical activity throughout the day. But at least these results are promising in the short term, that the kids did not eat back the calories, and in fact, they had a reduction in, or nice energy deficit, particularly in these moderate to high intensity conditions. If we look at we were also interested in understanding the psychosocial outcomes. And so for mood, we see here mood improved in both the normal weight and overweight obese individuals. And we can see here that when they rated themselves as good and very good throughout the entire high-intensity condition, and overweight was much. They started out a little bit lower, saying they felt good, but by the end of the day, they felt great. And we can also see here for blood pressure responses that there was really no change for the healthy weight individuals. But if we look at the overweight individuals, particularly systolic blood pressure, with the 10 minutes in the very beginning, we see a nice decrease here for the high intensity. 20 bouts might be too much, but for the 10 bouts that they did in the laboratory, we see a nice decline in blood pressure. So what can we take this into the classroom? Can we take this into the schools? This is one of the interesting things that we wanted to understand. Is this a feasible way to increase physical activity in schools? So we went into 3 different schools, elementary schools throughout Michigan. And what did we find? We found that the teachers could do 5 activity breaks throughout the school day at about 4 minutes per day. So instead of doing 2 minutes with a bunch of different activities, they could do 5 if we make it a little bit longer, and that's about 20 minutes of physical activity in the classroom each day. We also know that transition times were shorter. The kids were back on task. These are important things that the teachers were very interested in. The kids were exercising at a moderate to vigorous intensity, and the kids definitely enjoyed the activity. They rated the activity breaks as 4.2 out of 5, and their confidence to complete 30 minutes of activity in school was an 8 out of 10. And we were excited about these results, that even though we didn't get 40 minutes in the classroom, we got 20 minutes. And if you look at the recommendations from the Robert Wood Johnson Foundation, 19 minutes is what is recommended in the classroom. So it seems like this is a feasible way to get kids moving, all kids, irrespective of weight status, get them moving to improve the amount of physical activity they're doing in a day. And this is very important because a lot of schools, we know, despite these obesity concerns, we're seeing quite a few gym classes being cut around the country due to the emphasis on standardized testing. So real quick, the last intervention I want to tell you about is what role does technology play, and can we use technology to increase physical activity? We knew that there is this big fad going on a couple years ago with Pokemon that really increased physical activity, and young children are always using technology, so can we use this methodology to increase physical activity? And again, the spoiler alert is yes. Amy Christensen did a community-based intervention. So again, helping kids get physical activity with their families in a community setting. Again, they didn't just look at exergaming. They looked at, it was a multidisciplinary weight management program where 48 overweight and obese children, again, mean age 11 years, participated with their families in a 10-week, 2-hour sessions at a local indoor park. And the 3 different components included facilitating activity with exergaming, nutrition education, and behavioral management discussions. Quickly, the findings were that we saw nice reductions in behavior, so soda intake decreased, TV or screen time decreased, and more eating at the table, so family eating. We know that the more we eat in front of the TV, the more that we'll eat in general, which can lead to increased weight status. So these are some behavioral changes that occurred. In terms of intervention effects, we saw significant reductions in BMI, improvements in behavioral conduct, and improvements in self-worth. So the children felt better about themselves. So we saw both metabolic and psychosocial benefits from this intervention. So if we review all 4 exercise interventions, we see that yes, with strength training, we can improve body composition, psychological outcomes, and metabolic profiles. Aerobic exercise can also improve fitness, body composition, and metabolic profiles. Intermittent activity can do the same thing as the aerobic. If we just break it up, that might be a more feasible dose for kids to exercise. And then technology is another way in which we can increase physical activity and maybe even reduce BMI. So I want to thank you for your time, and again, thank the Alliance for giving me an opportunity to speak, and I'd be happy to take any questions.
Thank you, Dr. Hasson. That is very interesting, and I appreciate your taking the time to present to us today. Just for folks, we are going to move into a Q&A session, and just a reminder to type your questions into the chat box in your lower right. We're also at our 30-minute, half an hour for the webinar, so we'll stay on to address questions, but certainly for anyone who needs to leave, thanks for joining us today. I'm going to put a quick shout to our next month webinar down there in the chat box. But I did want to just make a note for Dr. Hasson. For anyone who's listening, she presented this at the Obesity Week conference earlier this month on behalf of the Alliance, and it's such a great message to give. We know that weight management is effective for OA prevention, and that starts with kids, especially with the obesity epidemic across all ages and certainly starting in childhood. So I think this is really important work that you're doing. So.
Thank you.
So we'll give folks a second to address any questions. We also were recently attending the Movement is Life caucus in Washington, D.C., which focuses much more on health disparities. I don't know if you're familiar with that conference. But I was curious when you said initially early on in your talk, of course, you were addressing kids who are African American and Latino and going into schools in the Michigan area and so forth. Did you have any issues with getting kids to participate in terms of building trust and going into the community and addressing health disparities in that way?
No, that's a great question. And a lot of times when we were doing our school-based interventions, we were really nervous about either it was in the laboratory or in the schools. We were nervous about our children that were have overweight or obesity, that they would not participate or they would not want to, or they'd be a little shy. But I think one thing that we focused on quite a bit was the enjoyment. So watching the videos, doing maybe just a Just Dance video, and making the activities fun. I mean, they totally forgot that, they were moving and they were just having fun dancing along to the videos. So we did not have any difficulties getting the boys or the girls. The girls were just as active as the boys, and the kids that were a bit heavier were just as active as the kids that were at a healthy weight. And I think the smaller dose, again, it's not enough to induce a large sweat response. So the children were able to just, have fun and play, but also refocus their attention. I think the biggest barrier to the activity, again, it's not the children, but it's more so the structures that they're in. So trying to help teachers find ways to infuse that physical activity into their classrooms, trying to find ways to get buy-in from principals that this is a way that we can improve movement and learning in the classrooms. But we know that schools, particularly low-income, under-resourced schools, have a lot of strains and demands on them. So it wasn't really the kids that were the concern. It was the environment that they're housed in. How can we make that more conducive to physical activity?
Right, and as you said, that definitely helps with learning and attention to give kids a break and a boost here and there. So, I think it's a little distressing to learn that schools are removing the gym classes, like you pointed out at the end there, just because I think that's, in addition to the obesity issue, that's such an important part of the day.
Right. And the comprehensive school-based physical activity programs has traditionally been the primary mode by which children are getting physical activity. They get most of their physical activity at school, but back in 2001, with the changes in policy, we saw a shift in the amount of time that was allotted for academic instruction because of the emphasis on standardized testing, and physical activity was essentially time for physical activity or physical education was reduced quite a bit, and even some states now don't have any standards for PE activity or regular or allowed. There's even schools that don't even have recess anymore. So I think trying to find ways in which we can infuse physical activity back into children's natural environments is a way that we can get them to move a little bit and then transition into exercise programs.
Yeah, and that leads into this one question that came in, which I was wondering myself. Do you know if the children continued to exercise after the study was over?
Which study?
After your intervention.
Oh, in the schools?
Mm-hmm.
Or for the strength training intervention, what we actually did is we had a low-cost maintenance intervention it was about 8 months. And so the strength training was only 4 months, but we had 8 months where we would send them newsletters once a month giving them information about, why it's important to stay healthy. Here's some nutrition information. Here's some examples, strength training things that you can do on your own, and giving them information about resources in their community to stay active. Like you can go to the YMCA instead of coming to the lab to do your strength training. And then there was also another maintenance program where kids would come back to the lab and every couple of weeks, and we would do little booster sessions with them. And we demonstrated that there was no difference in the maintenance of health outcomes, that the kids in either group, whether it was the nutrition or nutrition plus strength training group, they maintained their physical activity, they maintained their improvements in metabolic health 8 months post-intervention as a function of both interventions. So even just sending newsletters to the kids in the mail once a month helped them to remember everything that they learned from the intervention to maintain their physical activity. For the school-based intervention, 70% of the teachers were still implementing physical activity breaks in their classrooms, and many of the kids would go find physical activity videos online at home and would do many of the videos at home. They just got such a kick out of it that they would do it, ask their brother or sister to do it with them. And so I think that there is a model for translating what they're doing at school to maybe put a little physical activity homework that they have to do a couple of videos when they get home, and maybe they can encourage their parents to do it with them as well.
That's a great idea, and that's a pretty impressive return that your teachers are continuing at a rate of 70%. And I think it's also, you illustrate what it takes to get people to instill behavior changes like this by sending them monthly newsletters. And, it does take some effort for folks who are not perhaps naturally inclined to be physically active. It's a lot. And I think it's really the key is to get people to instill these behaviors regularly. That's the hardest part.
Right. And I think that one of the things that we have forgotten is that leisure time physical activity really hasn't changed that much over the last 50 years, but what has changed quite a bit is how much physical activity we get going to and from school, going to and from work, how much physical activity we get at work, at school. Those are the main domains in which our physical activity has declined drastically because we're typically not in manual labor jobs anymore. We're more in white-collar jobs where we're sitting at desks all the time. So, if there's a way in which we can redesign our work and school environments to bring back some of that physical activity, that may help stay some of the weight increases that we're seeing in both children and adults.
Right. You're so right. I see that even in my own life. Just, I consider myself to be very physically active, and yet so much of my day is spent at a computer or in sedentary state. So, for those who are not regularly physically active, it's definitely an issue. So I appreciate that. Well, very good. We don't have any other questions that came in, so we're probably just going to go ahead and wrap up. Thank you very much, Dr. Hasson. This has been a wonderful discussion and good presentation. I appreciate your time.
Great. Thank you again for the invitation.